Good morning, everyone, and welcome to another High Rounds. I first want to start off by welcoming some of our applicants who are joining rounds with us today, and it should be really exciting rounds. And I hope I don't get anyone's names wrong. I'm sorry. Elizabeth Luengas and Chong Charis. I hope that I did okay. Anyway, welcome. We're really glad that you're here and hope you enjoy this and learn something. But now onto our presentation. We have someone visiting virtually as it is these days. We're really excited because this was a case that we actually at the Owen Clinic were trying to help Dr. Dickter with, and it's really interesting. So I hope you'll get some more perspectives on it today. But let me introduce Dr. Jana Dickter, is an associate clinical professor in the Department of Medicine, Division of Infectious Diseases at City of Hope Comprehensive Cancer Center. She's board certified in internal medicine, infectious diseases, and the American Academy of HIV Medicine. She went to undergrad and got an undergraduate degree in cognitive sciences from UCSD. And then she received her medical doctorate from Rush Medical College in Chicago. After an internal medicine residency at University of Pittsburgh, she began her fellowship at UCLA's program in infectious diseases. In her clinical work, she is focused on the management of infections in the immunocompromised. At City of Hope, she is an on-site HIV specialist and has an interest treating people who are living with HIV and cancer. She was the principal investigator involved in presenting the case of this City of Hope patient, prolonged HIV remission without antiretrovirals after allogeneic hematopoietic stem cell transplantation of a CCR5 delta 32 mutation donor cells for AML. It's a good mouthful, but also very cool. She also serves as the HIV physician for the first in human trial to evaluate the feasibility, safety, and engraftment of zinc finger nuclease genome edited CCR5 modified CD34 hematopoietic stem progenitor cells in HIV infected patients. And with that, I will turn it over to Dr. Dickter. Thank you so much for being here.
Hi, good morning. Thank you for having me. Okay, so this case actually is another hematology case, so expect some mouthfuls of words, but I'll try to go as thoroughly as possible. Anyway, so today I'm presenting a complicated case of persistent HIV viremia despite appropriate antiretroviral therapy, and I would like to thank the people in the audience from UCSD who helped me with this case, and I'm interested in getting other people's thoughts in this case and hope to have a discussion at the end of this talk. So our patient is a 48-year-old man. He has a history of HIV that was diagnosed in 2015. And at that time, he was advised on starting antiretroviral drugs and decided against initiating medication due to unwanted side effects. By August of 2017, his CD4 count had dropped to 59 cells per microliter, and he was started on Triumec, lamivudine, abacavir, and dolutegravir. But unfortunately, in September of 2017, he started having memory and orientation issues, and imaging of his brain revealed a 3.3 centimeter right temporal mass. This was biopsied and was diagnostic of CNS lymphoma. His bone marrow biopsy was negative at the time, and PET-CT scan showed some mediastinal adenopathy, but a biopsy of these lymph nodes was negative for lymphoma. He started induction therapy with methotrexate, completed 6 doses between October and December of 2017. But due to progressive disease, he was treated with rituximab, dexamethasone, cytarabine, and cisplatin, and had a mixed response. And in April of 2018, he was started on salvage chemotherapy with rituximab, ifosfamide, carboplatin, etoposide, and lenalidomide, and had a good response. In June of 2018, up at UC Davis, he underwent an autologous transplant with conditioning regimen with carmustine, etoposide, cytarabine, and melphalan. And the reason he went up to UC Davis was that he was enrolled in this clinical trial, which was a phase 1 study of stem cell gene therapy for HIV mediated by Lentiviral Vector transduced pre-selected CD4 cells. Post-transplant imaging showed some enlargement of the lymph nodes in the mediastinal region. And so in November of 2018, he underwent biopsies of 2 of these lymph nodes, which were negative for lymphoma. There was 1 lymph node which was inaccessible for biopsy. So they decided to follow him radiographically, and follow-up imaging 5 months later continued to show these enlarged mediastinal lymph nodes with hypermetabolic activity. And he continued to be monitored. And I'll dive into more of the details of his HIV treatment in a few minutes. But first, I wanted to mention at this time, roughly in early 2019, he was off his antiretrovirals due to some problems with insurance for a couple of months. By June, he was back on antiretroviral drugs, and his hematologist started lenalidomide. His course at that time was complicated by cytopenias. He was treated with GCSF, but this was shortly discontinued due to persistently low counts. And follow-up imaging by October of 2019 showed improvement in his mediastinal adenopathy, and repeat imaging thereafter for his lymphoma was stable or improved. His post-autologous transplant course was complicated by 3 episodes of CMV viremia, which were treated with valganciclovir and ganciclovir. He had no evidence of end organ disease at that time. He also had a history of condyloma and underwent resection of the perianal area in December of 2019. And he had syphilis that was treated in the past with a positive RPR, and subsequent testing has been, RPRs have been non-reactive. In March of 2021, he was diagnosed with myelodysplastic syndrome. At that time, he started chemotherapy with azacitidine and venetoclax, and he completed 7 cycles, which was last received in March of this year. I saw him for the first time in August of 2021, so a little bit before then, at which time, when he was diagnosed with MDS, he was being evaluated for allogeneic transplant. And he was complaining of some GI issues at that time with nausea and diarrhea, and was ultimately evaluated by gastroenterology and was diagnosed with pancreatic insufficiency. In November of 2021, he was started on pancreolipase and had improvement in his symptoms. By May of 2022, his myelodysplastic syndrome had transformed to acute myelogenous leukemia, and he was admitted to the hospital for induction chemotherapy with fludarabine, cytarabine, and idarubicin, and venetoclax, and this was started in May of 2022. He had a prolonged hospitalization at that time. His course was complicated by tumor lysis syndrome, respiratory failure, probable invasive pulmonary aspergillosis that was treated with posaconazole, and acalculous cholecystitis, which was managed conservatively. And unfortunately, his follow-up bone marrow biopsy continues to show increased blasts. His other complications associated with his leukemia have included low platelet counts, which have led to subdural hematomas. And he's also had GI bleeds. Both of these have been treated with platelet transfusions. And he also developed CMV retinitis. So this was his first time where he developed end organ disease, treated with intraocular injections along with valganciclovir. And as of today, he still is on maintenance valganciclovir for this. So next is a summary of his HIV history. And as you'll see, almost all of his viral loads have been detectable, except once in 2018. So you can see, I got these results from our electronic medical record and in discussion with his outside HIV doctor. So he had many of these viral loads were obtained both at City of Hope from his primary doctor, and also from UC Davis when he was up there undergoing autologous transplantation and on this study. And as you can see, he had detectable viral loads this entire time. There was one episode where he had a detectable viral load less than 20 in June of 2018. That was right before his transplant. but subsequently he had persistently persistent viremia. In early 2019, so probably around this time, he was out of his medications due to insurance issues. And his outside doctor, when he reinitiated drugs, restarted his Triumec and added rilpivirine at that time. But because of the persistent viremia, presumably in mid-2020, his HIV doc outside started him on Biktarvy and Doravirine. And at that time, his outside doctor did a genotype which showed no evidence of resistance, including to integrase inhibitors. So he was maintained on these drugs, and I saw him for the first time roughly in August of 2021, at which time the reason for consultation was his hematologist wanted to take him for allogeneic transplant for his myelodysplastic syndrome, but he wasn't considered a candidate for transplant until his viral load was undetectable. And there was also a question about transplanting him with an unrelated donor who carried the homozygous CCR5 delta 32 mutation. And this is a rare genetic mutation that renders people who carry it resistant to contracting HIV R5 virus. He actually had two donors. One was his sister, who was a match-related donor, and then this matched unrelated donor. So when I saw him, I ordered a PhenoSense GeneAssure with integrase and a Trofile. And the PhenoSense GT came back indeterminate. His Trofile showed R5 virus. But in follow-up, because of this indeterminate test in September, when I saw him, I ordered a GeneAssure archive, which showed no evidence of significant resistance. And it was around that time when he was having some of these GI issues with nausea and diarrhea, and he was referred to gastroenterology, at which time he was diagnosed with pancreatic insufficiency. So with the diagnosis of his pancreatic insufficiency, his primary doctor started him on injectables. He was on Cabenuva with rilpivirine and cabotegravir, with the idea that we would be bypassing his GI tract. When I saw him after, I was a little concerned about the possibility of NNRTI resistance, because he had been heavily treated in the past with Doravirine and rilpivirine with persistent viremia. And so after discussion with his primary doctor, we decided to initiate ibalizumab injectable and boosted darunavir. And it took some time for him to get these medications due to insurance issues, probably a couple of months actually. And by that time, his GI issues had improved with the initiation of Creon. And despite this addition, his viral load increased. He was admitted to the hospital in May. That was when he was started on, he received induction chemotherapy. And upon the day of admission, we decided to get a darunavir level because we were curious to see if he was taking his drugs. And his darunavir level on the day of admission turned out to be quite therapeutic. So it appeared he was taking his medications. So because of his persistent high viremia, we decided to repeat genetic testing and repeat a Trofile to see if he had transformed, if this virus had changed. And at the same time, we broadened his antiretroviral drugs with the intention to pare down his therapy with once we got his genotypic and phenotypic results. And we discussed this case with some of the members in this audience at UCSD. And T20 wasn't an option because he was very thrombocytopenic. So doing injections was not really an option. And we were concerned about the possibility of drug interactions with fostemsavir and posaconazole because he had probable invasive pulmonary aspergillosis causing QT prolongation. And so at the time, we decided to start him on emtricitabine, tenofovir, alafenamide, dolutegravir, which was dosed at BID dosing out of concern for integrase inhibitor resistance, darunavir that was also dosed at BID dosing out of concern for resistance, and Maraviroc, and he was maintained on the ibalizumab. Unfortunately, repeated attempts at genotypic and phenotypic testing failed. And finally, we were able to get a GenoSure archive by July, which again showed very similar results to the preceding year, no significant evidence of significant antiviral resistance. And when he was released from the hospital, we again tested his Viremia level outside of the hospital, and he was again therapeutic. So regarding the genotypic and phenotypic testing that we did, multiple amendments were made, and this included PhenoSense GT plus integrase testing, which failed repeatedly. We sent next generation sequencing to different labs, and they continued to come back indeterminate. And we were only able to do successful testing on 2 separate occasions in August of 2021 and July of 2022, despite this persistent viremia. And because of this, I discussed this with 2 pathologists up at ARUP and Monogram, because we were wondering, why are these tests continuing to come back indeterminate? And one of the theories that came back was that some medications can cause inactivation of HIV primers, and heparin is one of the more common ones, but there are others. And so because this patient had MDS and then leukemia and was on all these drugs, perhaps it was an unknown medication, or it was heparin. Maybe they were getting these labs from his portacath, and there was some interaction with the heparin. So we tried asking for the lab to draw his this blood work from the periphery, and it still came back indeterminate. Profile testing continued to show R5 virus, and as I mentioned, his Viremia levels were therapeutic. We contacted Monogram to test the virus against entry agents, and this test was done in July of 2022 when he was in the hospital. And the virus showed susceptibility to all the entry agents, Maraviroc, which he was on, and also ibalizumab. And the maximum percent inhibition was 100% for ibalizumab and 99% for Maraviroc. So where is this virus coming from? And why do people think his virus is not undetectable? And so first I'm going to go.
Sorry, Jana, really quickly, I think this was posted. I think you had this at the beginning, but may have been someone who joined late. Were you able to obtain a GenoSure Prime before he began ART in 2017? Did you have his genotype from?
I do not. I do not have that.
Okay, so as far as we know, it was not obtained, because that should be something you should be able to obtain from Prime.
Right. Yeah, no, I never was able to get a copy of that. I don't believe it was ever done.
Okay.
And there was no record of that.
Got it.
Ever being done.
Thanks. Sorry.
Sure. No problem. So first I'll just go through some definitions, and this table was taken from the Ontario HIV Treatment Network that summarized the major guidelines for definitions and management of HIV viremia. And probably everyone in this audience knows the U.S. Department of Health and Human Services defines optimal viral suppression below 20 to 75 copies, depending on the assay that's used, and low-level viremia is defined as detectable levels less than 200 copies per milliliter. And guidelines recommend that management strategies be individualized, with steps being first obtained to verify the viremia and evaluate for adherence issues, possible drug interaction issues. And current recommendations indicate that patients with HIV viral loads less than 200 typically don't require changes in drugs unless, because it's thought that the concern for emerging resistance may be low. But it is recommended that these patients be monitored closely. But our patient doesn't have, by definition, low-level viremia because his viral loads are much higher. And virologic failure is the inability to achieve or maintain viral suppression and viral replication to a viral load less than 200 copies per milliliter. So these higher levels of viremia, even when they're less than 1,000, are associated with virologic failure, viral evolution, and the emergence of drug resistance. So, so some issues that are associated with virologic failure are patient adherence issues, HIV-related issues, or antiretroviral drug-related issues, and some patient-related issues that can impact persistently positive viral load include comorbidities that may impact adherence, unstable housing or other psychosocial issues, missed clinic appointments, interruption or intermittent access to antiretroviral drugs, cost and the affordability of HIV drugs, or high pill burden or dosing frequency. And for our patient, adherence certainly had been a problem before he had run out of insurance in early 2019. And I think there may have been some issues with compliance in 2020 and 2021, possibly, although we never really able to verify that. But it wasn't really until December of 2021 when he was on injectables and we knew he was absorbing those drugs that we knew for sure that he was taking his medications consistently. And this was confirmed when he was admitted to the hospital in May when his Viremia level was therapeutic, indicating he had been taking his medications. And in terms of drug interactions, I can't speak to what happened before I saw him, as I don't have a full list of his drugs during his autologous transplant, but I can tell you when we saw him and started him on all these drugs in May, we dose adjusted his ritonavir, his Moraviroc, and his venetoclax to mitigate drug interactions. HIV factors that can impact persistent viremia include presence of transmitted or acquired drug-resistant virus, prior HIV treatment failure, innate drug resistance to prescribed antiretroviral drugs, or higher pretreatment HIV RNA levels. And for our patient, the questions as to presence of transmitted or acquired HIV-resistant virus is possible. Our patient admitted to having multiple acts of condomless sex with partners who may have had HIV. So is it possible he contracted a superinfection with another strain? He also had multiple, documented antiretroviral therapy treatment failure in the past. And HIV antiretroviral drug related factors that can impact persistent viremia, suboptimal pharmacokinetics, suboptimal virologic potency, a low barrier to resistance, reduced efficacy due to prior exposure of suboptimal regimens, food requirements, drug interactions with other medications, or prescribing errors. Our patient had a history of pancreatic insufficiency, so could he have been having issues with malabsorption, particularly when I first saw him in August of 2021? It's possible that may have contributed to his viremia. And also the possibility of suboptimal treatment in December when he was switched to Cabenuva, that may have been suboptimal therapy, and new guidelines from the NIH as of last month recommends against the use of long-acting antiretroviral drugs with intramuscular cabotegravir and rilpivirine in people who have detectable viral loads due to suboptimal adherence. But despite all this, his resistance testing continues to show no evidence of resistance. So this is where I kind of would be interested in getting some thoughts from the chat box, why people think that he has persistent viremia. Do people think it's non-adherence, malabsorption, resistance to antiretroviral drugs, clonal expansion of CD4 cells with underlying malignancy, HIV superinfection, prior gene therapy with lentivirus, or something else? Okay.
Sorry, I should read for you. There's an assortment. I'd say the majority of 7 people are saying D, but a lot of people are selecting more than one. There's also been a B, a C, an F, and a G. So no A and no E.
Okay.
Yeah. For whatever that's worth.
Okay. So everyone's all over the place.
Well, I think we've removed A and we've removed E.
Okay.
I think that's where we are.
Okay. All right. Very good. Okay. So I'll tell you kind of my thoughts. With non-adherence, again, probably early on, but currently there's been no evidence of it since end of 2021 and early 2022. Malabsorption absolutely could have been an issue back in 2021, but since he's been on Creon, it seems like he's absorbing his drugs with therapeutic darunavir levels in and out of the hospital. That seems unlikely. Resistant to antiretroviral drugs, his GeneAssure Prime testing and entry agent testing at Monogram shows no evidence of resistance. But what about other possibilities? Clonal expansion of CD4 cells with underlying malignancy, HIV superinfection, other gene therapy with lentivirus or other. Okay, so first I want to talk about where the virus could be coming from, and then I'll talk about other possibilities for persistent viremia. So this figure was taken from a review of persistent HIV viremia on antiretroviral drugs, and this was published in Frontiers in Microbiology. And this figure shows that there's two main sources of persistent viremia in people living with HIV on antiretrovirals have been identified. And the first is seen in the top portion of the slide, where you have productive cycles of ongoing short-lived viral production by the activation of HIV-infected cells, where infected CD4 cells produce bursts of virus and then die. And these complete cycles of viral replication cause the accumulation of mutations due to the error-prone nature of reverse transcriptase. And additionally, many integrations of proviral DNA insert themselves into different locations in chromosomal DNA. So the consequences of this are the production of HIV viruses with different sequences. The second source of persistent viremia in patients on antiretroviral drugs is shown in the bottom part of this slide. And this demonstrates ongoing viral replication from reservoir cells or clonally expanded T cells. And these progeny carry identical HIV proviral sequences and identical integration sites. And it's possible that a small number of these progeny can contain transcriptionally active proviruses that can produce infectious virus. And studies have recently demonstrated that most low-level viremia probably arises from clonally expanded T cells rather than ongoing viral replication, but it's possible there could be some degree of both processes going on. So I'll go through a couple of interesting publications that may shed light on some of this, a source of the persistent viremia in people living with HIV despite antiretroviral drugs, appropriate antiretroviral drugs. One study was done by that evaluated 8 individuals with persistent HIV viremia for over 6 months at two or more time points. And these tests were done despite reported adherence to antiretroviral drugs and the absence of drug resistance to the current drug regimen. And they found for all subjects over 6 months, the viral sequences were identical and didn't change over time and did not evolve resistance to the antiretroviral drug regimen. And a second study with more patients, which looked at these samples for almost 5 years, sequenced polymerase and envelope genes from the viral populations, and again, found no evidence of genetic evolution, no evidence of active viral replication that was thought to be the main driver for low-level viremia. So in summary, both of these studies suggest that for patients with low-level viremia, the main source of virus probably arises from clonally expanded T cells rather than from ongoing viral replication. Now, this is again for low-level viremia, and our patient had more high-level viremia, but I thought this was interesting information. And But one question that kind of arose was, is it possible with our patient's hematologic malignancy that there was an associated clonal expansion of infected lymphoid or myeloid cells? Now, I looked in the literature and I couldn't find anything in patients with hematologic malignancies. I'd be interested if anyone in the audience was aware of any cases, but I did find this case report that was reported by Meller's group. And they described an unusual case of a patient with squamous cell carcinoma of the tongue with HIV who had persistent HIV viremia despite antiretroviral drugs. And this patient's viral load went up to almost 1,000 and at certain points during his therapy. And this group found that this patient produced identical viral sequences from a clonally expanded cell that contained an intact infectious provirus. Now, this provirus, they called it AMBI1. And what was interesting was that the level of this provirus in the plasma was associated with his cancer treatment. So when he received treatment for his cancer, the levels went down. And then when his cancer recurred, the levels went up, suggesting that there was an association between the extent of his tumor and the amount of clone carrying this provirus. So the figure on this slide represents samples that were obtained at autopsy from the primary squamous cell carcinoma and some of the metastatic lesions. And panels B and C show tumor infiltration by CD4 lymphoid cells. Panel D shows the HIV cells that were detected in all the lymphoid and metastatic lesions that were tested. And this provirus and the integration sites that were detected in DNA derived from both tumor and lymphoid tissues were present at significantly higher levels in the cancer metastases rather than lymphoid tissues. And so this demonstrates that the tumor and its metastases can actually contain highly expanded clones of HIV-infected CD4 cells that can produce infectious provirus, leading to persistent plasma viremia. And I think most of the people in the chat didn't think superinfection was an issue. Again, our patient did report that that was a possibility, but a review of HIV superinfection in Lancet Infectious Diseases shows this graph where you can see that the representative clinical and virologic aspects of HIV superinfection. And as you can see from this green line, you usually have these spikes in viremia, and our patient never had that. Also, what kind of speaks against it is our patient had two tests which showed no significant genetic changes about a year apart. Both tests continued to show subtype B virus and R5 trophils. So that seemed to be less likely. So before I contacted UC Davis, the hematology notes had indicated that the patient had participated in a clinical trial aiming at CD4 stem cell modification to be resistant to HIV entry. And I was interested in learning more about what trial he was on, because I was wondering if something happened with the cells that were, impacting this persistent viremia. So I was able to get a copy recently of the protocol, and the title of the protocol is a phase 1 study of stem cell gene therapy for HIV-mediated Lentiviral Vector transduced preselected CD4 cells. So this lentivirus that they created combines multiple anti-HIV genes into a single lentiviral vector that's designed to block HIV infection at different stages of the HIV life cycle during entry, encoding, and viral transcription. And the three components included CCR5 knockout, which again provides protection against only R5 strains, but that was one of the components. The second component was this human rhesus macaque chimeric TRIM5 alpha, which acts as the pre-entry, pre-integration stage of the life cycle. And the macaque TRIM5 alpha isoform are strong inhibitors of HIV, but the humans don't. So they created this chimeric isoform, which incorporated critical amino acids of the rhesus macaque isoform necessary to inhibit HIV. And finally, they included this TAR decoy, which acts as the pre-transcription stage of HIV-1 life cycle and scavenges the HIV TAT protein away from its normal function in HIV proviral transcription. So some questions came up from the study. So here at City of Hope, we do a lot of CAR T therapy, and CAR T therapy is, for some of the people in the audience, mononuclear cell collection, T cell purification, and reprogramming of T cells for cancer therapy. And what they use is either HIV-1 derived lentivirus or gamma retroviral vectors to recognize receptors that are expressed by cancer cells, and that these cells then target and kill cancer cells. And these vectors use HIV genes encoding the viral envelope and GAG polyprotein and the polymerase to help guide the CAR gene to the patient's T cells, allowing it to integrate and transform the cells. And for gene therapy trials, more commonly, they're using these lentiviral vectors because they apparently are more predictable, have more predictable integration profiles rather than the gamma retroviral vectors. There's several reports of false positive HIV nucleic acid testing reported in the literature due to cross-reactivity of HIV nucleic acid tests among patients receiving CAR T therapy due to the conserved regions of HIV. And looking at the literature using the lentivirus vector therapies, cross-reactivity has been most frequently identified with nucleic acid tests targeting the LTR and GAG regions of the HIV genome. So specifically, Roche Cobas Amplified Prep and the Cobas TACMan HIV-1 test version 2.0. And what's interesting is that these two parts of the genome are commonly used among many CAR T lentiviral vectors. And our patient, both of these platforms were the tests that were repeatedly used to test his viral load at UC Davis, at City of Hope, and at his primary HIV doctor's office. So when our patients when we started using more CAR T therapy in patients at City of Hope, we actually created a HIV PCR test to be created for CAR T patients specifically in our electronic medical record. And this test uses the Abbott M2000 real-time HIV-1 assay, which targets the integrase gene. And to date, the literature hasn't described any CAR T patients with false positive HIV PCR tests using this assay. So other questions that possibly could have come up when I discussed this case with the trial team was, is it possible that the lentivector recombined with replicating HIV? It's rare, but it's possible. And with the exception, they told me that with the exception of the portion of the GAG, most of the GAG and the PUL are not included in the vector, in this lentiviral vector after transduction. But if recombination occurred, it could have restored some of the GAG and PUL transcriptional activation. So the lentiviral vector may be driving HIV, GAG, and PUL, but not necessarily making HIV. And so, but it can look like they're circulating HIV with this nucleic acid testing. And the way to assess this would be genotyping of areas that would look like whatever HIV recombined with, but expression is being driven by the lentivector and not HIV. And then again, we wouldn't change his antiretroviral drugs based on these positive tests. So one of the other questions that came up is what happens with this gene therapy with the lentivirus? And here's this patient who now has, who developed myelodysplastic syndrome and now has acute myelogenous leukemia. And there are potential risks with the use of lentivirus. While they don't have genes needed to reproduce themselves, it's possible they can combine with other genes that it could activate an unknown virus. And this has the potential to lead to known or unknown medical problems, including the possibility of another cancer. And the study team believes his MDS and AML is chemotherapy induced because he was heavily pretreated in the past, but they are planning on doing more testing to assess this. As of now, the team did conduct lentiviral vector integration site analysis to assess if this adverse event is a clonal expansion of the investigational product. And to date, the results are consistent with previously published integration analysis for lentiviral and retroviral vectors. But due to this complication, we are planning on sending more labs up to them to evaluate if there is clonal expansion of the vector that induced insertional mutagenesis. So the punchline is that I ordered a blood test on him using our CAR T, what we do for CAR T patients who have lentiviral treatment, and on the Abbott platform. And his viral load was undetectable at less than 40 copies per microliter on that platform. So again, we are planning on sending samples up to UCSF for HIV and lentiviral gene modification vector sequencing and quantification, and also for flow cytometry to phenotype immune cells. But I think this case is really important to highlight because we are likely to see more patients who either are on trials for gene therapy or receiving CAR T therapy who are tested, who are treated with lentiviral vectors. And it's important that we keep that in mind when we order what tests we order to evaluate their viral loads. Thank you. So now I'd like to open it up for discussion.
Jana, it's such an interesting case. Yeah, a few of us were involved and I think we're just spinning our wheels about it. Oh, good. I see Bobby D has his hand up. Go ahead, Robert.
Hi, I think I'm Robert on the chat. I never know. Thank you for that talk. It was great. I was wondering, back to the question of the donor, and I think you mentioned that he had a matched sister, I believe that was possible.
Yeah. So yes, he hasn't undergone allogeneic transplant. I mean, the hope is that he will, but yes, he has a sister that's a match and an unrelated donor who carries the homozygous CCR5 Delta 32 mutation. Yeah.
Right. So in that setting, I guess then A, is he still considered not a candidate because of this viremia? And then B, which is the more optimal? Is it the matched sister or the unmatched, in terms of risk benefit? I'm just curious.
So it's a really good question. So when all of this was happening, when I couldn't get what appeared that he had persistent viremia, I had spoken to his primary hematologist, and the thought was to use the unrelated donor for that very reason. Right now, he has other problems regarding the reason he's not going through a transplant is that he still has quite active leukemia. And actually, he's hospitalized right now with a subdural hematoma, and they're having a hard time keeping his platelet counts elevated and are trying to get HLA matched platelet transfusions for him. So he's not right now a candidate for transplantation because of his active leukemia, not because of his HIV. But I think your point is well taken, right? Like, so which donor would you use? And I think that's going to ultimately have to be decided by hematology, in terms of deciding which donor would be the best donor. But now I think you could go with either one, and probably the decision will be will depend on what who the best donor is under the circumstances at the time of if that actually happens.
Great, thank you.
I just had a couple of comments. The first was, I mean, there really was a dramatic change in his, well, maybe not a dramatic change, but one log change in his set point, right? This was someone who was off for 2 months in the beginning and was in, you know, I think it was like 2,000, 4,000, something like that. And then, you know, had a log gain. To me, that sort of smells like something, you know, very different is happening. And I think, you know, and I know I was part of the group that was thinking about resistance and we have this, could you do this? But sort of putting it all together really does, I mean, it really did sound like it was something totally different. The comment I also made to you, and this is where sometimes I'm known as Dr. Death, you know, is sort of where are we going with this? Sorry, I'm not really Dr. Death, but I do, you know, think about sort of what this means for this person and sort of what he has been through, just describing the comorbidities and the complications he's had, you know, where are we with all of this? And I lost, oh, there's Randy. And I don't want to say that because I know there's always hope at the City of Hope and in general, but it does strike me as, you know, sort of where are we going with this? Anyway, those are just 2 general comments. I don't know if someone else has a comment. I think Lucas has a great question because I think when in our conversation with you, we ended up saying how much is going to the simplest regimen possible. So I don't know if anyone else wants to say, but I think we're curious where you are with the ARVs now.
Yeah, so I did de-escalate him because he's actually undetectable, right? And we have no evidence of resistance. So he's on, well, he's in the hospital right now. So because he had the anthracytidine, tenofovir, alafenamide, and dolutegravir, I just put him on that, and he's on once a day dolutegravir too. So he's on 2 pills a day now, as opposed to his multiple pills before.
And I want to give credit to, I think Carrie's on here, Carrie Eberholsen, who was like, you know what, I'm going to go in a different direction here. And I'm curious because the viral load that you got that you use for when people are receiving T-CART, could you, or CAR-T, excuse me, could you get the same viral load that you were like, did you do it simultaneously so you could actually show, look at the difference? Like, look how dramatically different we're getting results.
So I got him about 2 weeks apart, and
Okay.
so no, I didn't get him exactly at the same time. I
Just
probably should.
Really interesting, you know, to see that if there were, you know, what sounds like a discordance, but
well, because I de-escalated his antiretrovirals, my plan is to obviously repeat a viral load in about 4 weeks. So at that time, I can certainly get both tests. It'll be interesting to see what they show.
yeah. So there are a couple of comments. One is from Shannon, who was added to that list, one of our brilliant inpatient HIV pharmacists. So thanks for sharing these mechanisms for ongoing viremia. It can help explain what we've anecdotally seen in patients who get chemotherapy inpatient. And again, credit to Carrie. I hope maybe Carrie will unmute herself and make a comment because she was spot on with this. I don't know if Carrie, you want to say anything? Good.
Yeah, I'm here, Jill. I mean, I don't, the mechanism of it, yeah, that's like way above my head. But, looking at the case, it just didn't make any sense that this patient wouldn't suppress, with the addition of all those medications and getting injectables. And so I figured, why be on this? Something's going on that we don't understand. Why put him on all those meds if it's not helping? And we have seen in other patients who have chemo some weird things with viral loads. So I've always wondered, you know, is something else going on when somebody has some ongoing cancers. So, you know, that's, yeah, those are my thoughts.
No, and I think that's really interesting. Sorry, Jana, you looked like you were going to say something. I was just going to make the comment, our service is not often seeing the patients receiving chemotherapy just because of sort of the division of labor at our hospitals. But I know people look at it, and ID doctors are certainly involved, but I just wonder if and how often this actually could be occurring. I would assume that they would reach out to some of our pharmacists, but yeah, I'm curious if something sort of quite like this has happened and sort of went onto the radar for whatever reason.
Yeah. So first I wanted to say, like, what you mentioned earlier about that 1 log increase, I think that it will be really interesting to see if there is any evidence of clonal expansion that could be contributing to because what happened is his viral load increased when his leukemia got worse. So you know, you wonder, like, is there a clonal expansion or something that's going on that could be, you know, explaining that increase in viral load. So that's kind of will be interesting to see what the people up at UCSF and UC Davis find. And in terms of yeah, I mean, I think what's interesting is that this patient with all these viral loads that were obtained at all these different institutions, you know, including the institution I might add who did the trial, you know, they were using this other platform, and I think that it's people aren't as especially, like, I mean, we're not as used to CAR T therapy. Most of us haven't seen it if you're not at a cancer center. I just happen to see it very frequently because I work at City of Hope, but I'm sure if I was anywhere else, I wouldn't be as familiar with the mechanisms of it. So I suspect that this is something that needs to be thought about. You know, the different platforms are available rather easily. I mean, Monogram I ordered this Abbott platform through LabCorp, which sent it to Monogram. So if you specify what platform you want to use on your order, they're able to do it.
Very interesting. There was a comment in the chat about, you know, coverage with insurance gaps, which is you know, something we think about a lot, and it doesn't seem like it affects. I mean, it doesn't seem like it. I think what concerned me initially is when you said he was off for a couple of months, and I think that's what Larry's referring to. You know, maybe he was trying to stretch his meds, so then he was taking them in a, you know, he wasn't taking them well, and then he could have developed resistance, but it didn't seem like that happened. He stopped entirely. I don't know if there was another period of time where he's off meds. I may have missed that. But we are lucky that we do have a safety net in California compared to some other places, at least.
Jill, this is Shannon. Just to clarify what we've seen, it's more like transient low level. People get chemo and then it kind of, you know, resolves on the next check, and we go, oh, well, that was interesting. I wonder what that was, you know. So it just makes me wonder if some of these mechanisms are at play, but we've never looked at it systematically. It's just more anecdotally. We're like, I wonder why, you know, they had a little blip there or whatever. It's been kind of interesting.
This is Shannon, who's supposed to be off today. So thanks, Shannon. But
I couldn't miss this amazing talk. Thank you so much.
No, this I think really did a big wow. And your punchline was really, that's a punchline. So does anyone else have any other comments, questions? I know Randy's on, and she showed herself for a second. I mean, I'm just curious sort of to think, you know, what I brought up, but just, you know, what does this look like for this patient in general? I know she's been doing this a long time, and
yeah, so
not a long time.
I mean, it's interesting. I'm Randy. For those who don't know me, I was at UCSD for a gazillion years. and have been here at City of Hope for the past 2, having done sort of transplant infectious disease at UCSD and then coming up here as the chair of medicine and continuing to do infectious diseases. And I guess what I would say is, that there is a different mindset in a cancer center. Moore's Cancer Center or, City of Hope, where the entire institution is a cancer center. And there certainly is, an aggressive approach to individuals. It reminds me kind of early days in the HIV pandemic. I mean, we try to be very kind of mindful of what is appropriate and enter into conversations of goals of care and expectations. Those conversations here are driven by hematology, and and Jana can, I'm sure, attest to this. Some of the hematologists are, kind of more, willing to enter into those discussions early, and others have difficulty. I have never, again, in the comparison of Moore's Cancer Center versus here, it is common to see people, common may be too strong a word, but it is not that uncommon to see people getting their 3rd transplant here. So there is a sense that patients don't get referred here often until they failed a number of therapies. I think there's a sensitivity that if someone is coming here for that, to sort of, kind of start the conversation with not what we're going to do for you, but, what we're going to do if it doesn't work, it's difficult for a lot of faculty. I will say we have a very strong supportive care, and it's kind of growing, and, we're part of this IGCC, which is this goal concordant care throughout the country for cancer centers. And so there's a lot of work being done on trying to be kind of more mindful and get to those conversations, before the patients end up in the ICU. I don't know, Jana, do you have anything to add to that?
I think you said it very well.
It's a struggle. It's not always easy. No, and we appreciate so much what you do, because it definitely is a different way to look at things at times. So there was a comment from Jason Halpern, and everyone, Jason Halpern is going to give us a talk at some point. He moved from Louisiana to San Diego and is now the medical director. I think that's the medical director at Vista Community Center. So we're going to hear from him at some point. But I think just this is a great point, such an amazing case, essential to educate about CAR T, because I assume patients may have been denied transplantation and told that their viremia had to be due to non-adherence driving this. I think that this is a really interesting, I don't know if there's something you can do in terms of like a retrospective look at something like this. This was obviously very dramatic, but fascinating that this may be happening for other people. And I don't know, do you have any thoughts about that?
Yeah, I mean, I think it's interesting because, the reason that they consulted me was because of persistent viremia. And so and I think that it really, it's important that we look at these trials that these patients are on, try to actually get the protocols if we can. So that way we can really look at it and figure out what exactly happened. But yeah, I mean, I think that, hindsight being 2020, the question is, could he have been transplanted when he had myelodysplastic syndrome before all these other complications occurred? Because his CD4 count at that time was actually okay. And I think that, yeah, there was definitely, there very well could have been a missed opportunity on him to transplant him back in 2021 before he transformed to AML.
And I think you just answered the last question in the chat too, is what might you have done differently, knowing this information? And I don't mean you, I mean, the whole team. So great case. We're at 9:00. Thank you so much, Jana. And it's so wonderful to see Randy. It makes me bell. So we'll have to do this more, but really great case. Thank you so much. And hopefully you will keep joining us, and maybe we'll hear back about this case in the future. So, all right, everyone, have a good day and a great weekend. Bye-bye.
Thank you.